6 to 7:30. And everyone, please mute your microphone, and we'll have time for Q&A at the end. Thank you.
All right. Well, welcome everybody. Thank you all for being here. Just a few things before we begin. So my name is David Tomasi, and I already included just very few links in the chat relative to my research mostly. So research academia link in my faculty page at UVM. But of course, if there's any other question, Jen, who so wonderfully agreed to be the moderator tonight, can also help address those questions. I'll be able to access the chat box throughout the presentation, but I may not be able to, type and talk at the same time. So tonight we will talk about few things that to pain and pain perception. All right, let me just make sure that everybody's here so that nobody misses the introduction. I see there are a few more people connecting here. All right, just going back and forth. All right, good. So this is an experiential workshop, which means two things. It will be a blend between a lecture/presentation and then a general overview of what the practice of motivational interviewing is about. So let me start by telling you just a little bit about myself. I have two main hats here in Burlington at UVM. One is my research and academic hat, so to speak. I'm affiliated with the Integrative Health Program at UVM, which is hosted by the College of Nursing and Health Sciences. And I also teach other courses, mostly within medicine, neuroscience, clinical and developmental psychology, human growth and development, within the Department of Studies. And so most of my academic and research area focus. So there's still a little bit of background noise.
Please mute your microphones, everyone. Thank you. I don't know if I can mute all. I'm going to try to mute all, but I don't want to mute you, Dr. Tomasi.
No problem. I can always unmute myself. Okay. Thank you for doing that. So that's my research and academic activity here in Burlington. And then my clinical practice as a doctor, I'm working I work at the UVM Medical Center in the inpatient psychiatry department. So I work with adults, individuals, and I work on a variety of psychopathology, spanning from mood and personality disorders, all bipolar disorders, schizophrenia, schizoaffective disorder, and all forms of psychosis and other neurologically based issues. So those are the three main areas that I have the privilege to work on. So neuroscience, medicine, and psychology. And I would like to bring some of that expertise as part of the presentation tonight. We will focus on, and we will try to navigate, first of all, what pain is, and I will build upon some of the presentation that some of you had the chance to attend during the main conference day. And I will also provide some bibliographical reference in regard to pain transmission, in regard to nociceptive factor. But I will also like to talk about two main areas of intervention to both educate ourselves as provider, but also, in terms of self-amelioration, self-improvement, as well as in the clinical practice to promote health and well-being from a more holistic perspective. So let's begin with our slideshow. And again, feel free to ask me questions as we go in the chat area. But let me see if I can make the magic happen here and share the slideshow with you. Give me 1 second here. All right, good. So let's start with the first slide. And here we go. Wonderful. All right, so the title of tonight's presentation, Applying Motivational Interviewing nociceptive pathways, sensitivity, and self-perception. Now, I decided to only focus on a relatively small amount of slides tonight for two main reasons. One is that each slide is pretty much self-explicative of what the concept is. And the second thing is that I tend to talk a lot, and I want to be mindful of your time and to give you the chance to ask me questions. You probably notice a thick accent on my side. So I am from South Tyrol, which is this landlocked area on the border between Austria, Italy, and Switzerland on the Alpine mountain range. So I'll do my best to make myself as understood as possible, but please stop me anytime. So three main areas: nociceptive pathway, sensitivity, and self-perception, and how to target these three areas using a technique called motivational interviewing. Let's start with the first slide in a very brief description. What is MI? What does MI or motivational interviewing stand for? Motivational interviewing is a counseling approach. In the United States, this approach was developed by clinical psychologists Miller and Rolnick. Every time we talk about motivational interviewing, we should think, at least, this side. However, motivational interviewing, it's not a fully separated area of either counseling or coaching within psychology. It's actually based on Carl Rogers' person-centered and or client-centered approach to counseling and therapy, okay? Which is a method to help people commit to the difficult process of change. So let's already take a little break here. So you might wonder, well, this is a very charged and possibly biased approach to pain, because to think of a motivation as part of pain management might appear to some as maybe not be as empathetic as necessary to a person suffering, for instance, from physical pain. You might wonder, what has motivation to do with pain? Okay, is pain something that it's simply for personal interpretation? Where does the weight end in the nature-nurture debate when you talk about pain? Is pain simply something that we rehearse, that we learn? In other words, can we claim that we learn how to suffer more or less? Or is something that's entirely biologically based? And by biologically based, I mean, we'll see how we can approach that. Okay? But the first thing I want to mention here is that within motivation interviewing, two main things appear to be essential. The first thing is that it is an approach that exists on its own. So in other words, you can apply motivation interviewing to pretty much any field within healthcare, and to say even outside of healthcare. Okay? The main focus of motivation interviewing is to counsel clients or patients, okay, from a client-centered perspective. Okay? Tonight, we will talk especially about motivation interviewing within health coaching, and I will explain that in a second. But it's also important to understand that whenever we talk about motivation, we have to start from ourselves. And so it is interviewing simply because it is a form of talk-based intervention. It's not a full talk therapy necessarily, because one of the idea at the basis of motivation interviewing is that you are patient-centered, not because you simply want to be kind and nurturing to the person in front of you. These things are extremely important also from an ethical standpoint, but simply because the client is an expert, at least in the way they feel. That's an essential component of motivational interviewing. So for instance, just to give an example, it's a very pragmatic example. A person might come to me on the unit or even in the ED, and this person might complain about a physical pain in the in their lower back, and they rate their pain 8 out of 10. I'm gonna do all my screening, all my lab work, all my examination, CT scan, etc., and I don't find any etiological reason as to why this person feels that pain. Well, from the perspective of motivation interviewing, this is completely irrelevant. The fact that a person is reporting pain, it's all we need to know in order to help them. Okay? regardless of the presence of biologically based problems. So this is the interviewing element. You interview a person as a way to find out more about the person. But here's the thing, it's not finding out more about the person as in a clinical assessment perspective. Yeah? I want to make this clear. Motivation interviewing can be applied to clinical psychology, can be applied to emergency medicine, but it's not synonymous with any of that. Okay? It's a technique. And that's the interviewing part. The motivation stems from the idea that it's a very Rogerian idea that is predicated upon this positive regard to the person in front of us. Okay? And I will leave it at that for now, because this will warrant a more in-depth description. But the idea is that we can teach a person to self-motivate, to be in, if not full control, to increase the percentage of the perceived self-control over their biological processes, including pain. Okay? Now, since we're talking about motivation interviewing, we should also talk about, that's the next slide, how the process is constructed. And this will be a practical application. So let's just read the slide and I will explain. The process is twofold. The first goal is to increase the person's motivation, and the second is for the person to make a commitment to change. So let's stop here for a second. We are not assuming that there are either motivated people, and by motivated we mean more involved people, involved in their care and their well-being, and on the opposite side we have people that really are not involved at all. Everything is on a gradient, on a spectrum. Okay? So the first goal is to increase the person's motivation. Okay? Now let's stop here for a second. What do we mean by that? Well, we mean a variety of things. Again, when we think about positive regard, we mean that our ability to enter the sphere of a private understanding, self-understanding the person, simply means that we might see a person's potential, regardless if this person is able to see themselves, right? And a good example would be a classical clinical psychology example. A person might come to you with a depressive symptomatology. And of course, a depressive symptomatology is not just a alteration of mood and self-perception, although this is pretty problematic, but it also has very significant biological changes that will increase the likelihood of a more strongly perceived pain perception. Okay? So in other words, a person is aching physically on top of emotionally. Okay? And so a clinical psychologist or psychiatrist should at least be able to detect the possibility of making this person feel better. And this is to some extent very similar to what another form of clinical intervention within coaching would do in the context, let's say, of fitness and sports. Let's assume that a person would like to work on their diet and possibly work on their weight. Okay? They might be somewhat ambivalent from our perspective in terms of why they want to change their weight, why they want to get fit, but at least they share with us that that is the primary goal for now. Okay? And this is where motivation plays such an important role. Motivation as in, I can see the way you're presenting yourself at this very moment. I can see that you are concerned about being, for instance, overweight, but I can also see through you in the future, and I can visualize a better self. Now, here's the tricky thing. What's best in this gradient, it's not what's best for us. It's not our interpretation. Well, you should really lose weight, or you should really stop smoking. It has nothing to do with the way we perceive the goal to be. Once we understand what the client's goal is, then we can achieve their own increased insight by virtue of focusing on motivational interviewing. Okay? So this is the first part. The second one is commitment to change. What does commitment to change mean? Well, I always like to talk about etymology. the meaning and the origin of the word, commitment simply means to put one's mind into something, right? So to combine the current presentation to the expected future, right? So it has really nothing to do with our ability to rationally evaluate the present moment. In other words, you might say, well, I failed in this specific example. I failed too many times in the past. I start exercise, and after a couple of days, I just quit. I know that I cannot focus on that. Okay? Or I know that I change diets as I change toothbrush in the morning. I'm just not consistent. So regardless of the assumption of the client, commitment to change has more to do with a self-pact, okay? Some sort of inner contract the person does within themselves. And this is also what separates motivational interviewing from many, many other coaching approaches, okay? And bear with me for a second. I want to expand on that. What would be an issue if a person decides to work on physical pain, for instance, okay? And this person is embarking on a coaching approach so that each week they set up a new goal, and the person monitoring their incremental benefit, it's a sports and fitness coach, for instance, okay? A non-motivational interview, non-health and wellness coaching trained sports coach. Well, the idea is that this responsibility is externalized. It's not made our own. And of course, you might find yourself in two very problematic situations. One, with the fact that your pain will not decrease. Let's assume that you had a sports injury, and the sports coach is, so to speak, strongly advocating for you to exercise despite of your pain, in fact, against your pain, okay? So on one side, your pain is not going away, but you might also start to feel either a little guilty or ashamed because you're disappointing the person in front of you. And we know very well, based on the scientific literature, that this is not a good deterrent for pain, and B, intrinsic motivator. Feeling guilty is really not. And I'll expand on that. Now, how does motivational interviewing work? So I will talk about these main skills, and then we'll move on to the central part of this conversation, which is how to apply it to pain. So MI is essentially based on the OARS acronym, OARS. And those are 4 main areas of intervention, also 4 techniques, and also 4 attitudes within motivational interviewing. And I would like to give you a few examples for each of these categories. Now, the best way to learn these strategies is by virtue of having someone to talk to. So within motivational interviewing, strongly advocate that a person learning the skills practices with, for instance, a good friend or a member of their family, or even a coworker, someone with whom they have a balanced relationship with. And so the purpose is not necessarily to change anything, but to navigate a complexity of human behavior to support the person in front of them. So the letter O stands for open-ended questions. Now, this is something that seems to be quite common sense. The concept of open-ended questions simply means any question that cannot be answered in a binary code system. Any question that cannot be answered with a yes or no, in other words. A mini essay question, just as the one you can find in school, during quizzes and tests. What's the purpose of an open-ended question? Well, the purpose is twofold. The first one is to be the least possible judgmental from our end, right? So, because some of the closed questions simply do not add either any further information, and they don't really nurture the rapport you have with your client. For instance, what's the point for me to ask you, are you in pain? Well, it's kind of a tautological answer. If I'm not in pain, we're kind of, moving away from what we're trying to analyze tonight. And if I am in pain, well, this is an information that already considered obvious. For instance, if the client present themselves to me, or if the client was referred to my office by another provider. Another form of open-ended question, another area of benefits of open-ended question is asking the how. All right. For instance, let's assume that the person is struggling with physical pain. And the only thing we know about this client is that this physical pain has been somewhat well defined by the clinical notes we just read before we met this person. Okay. I don't know, throbbing pain or stinging pain or kind of sinusoid pain up and down. But this doesn't really reflect how the person feels about the pain. So even a question such as, how does it feel to be in pain? How would you rate your pain? How does your pain limit your everyday activity? Those are situations where, first of all, the client will be able to give us a much more precise way to interpret how the pain is activating their own system, okay? Because as we will see in the next line, and some of the presenters during this conference already mentioned multiple times, the pain, it's not just in your mind, but it definitely has very strong neural underpinnings, okay? So what does that mean to you? For instance, the exact same pain, let's say in a localized area, let's say a person might have a sports injury and they had to be bedridden for 3 months until their lower limbs feel better. From the social and emotional perspective, this will have a very different effect, whether the person is, for instance, an academic professor teaching online, in which case you can just sit and it will not affect your daily activity as much, as opposed to a professional athlete, okay? And so the how open-ended question does just that, prevents us from having a biased perception, and also allows the client to further transmit what that means for them. The second word here, affirmations or positive affirmations. Just because we are focused on the client, it does not mean that we should empathize to the client in an inappropriate way. What does that mean? Well, the research on empathy, it's a research that's been, on the forefront of clinical neuroscience for the last 25 to 30 years. And we know that very much in depth. We know that we have several centers that are responsible for empathy in our brain. And for the sake of time, I just want to mention the mirror neurons and the nerve growth factors and all those circuitry in the brain that allow us to understand the person in front of us by virtue of recognizing the capability that we have inside of us to feel exactly the same way as they do. And the research on mirror neurons, very, very quick, indicated that we can learn vicariously by observing another human being. And so those mirror neurons were first understood to be responsible for motor control. I can see a person riding a bicycle, and therefore, by observation, my mirror neurons rehearse the behavior internally, and therefore they allow me to eventually rehearse and then increase my skills in bicycle riding. Okay? They're responsible for this gray area at the connection between emotions and homeostatic processes. For instance, something that was studied in the earliest research analysis within mirror neurons, the mid to late 90s, by Giacomo Rizzolatti and his team. A person can observe another person chewing, for instance, on peanuts, and that internally they will start to perceive either an eagerness to eat or hunger, or at least the proclivity to feel some sense of commonality between the action and what the brain is perceiving. Common example in psychology, if I'm asking any of you to really close your eyes and concentrate and thinking about sucking on a lemon, the likelihood that you will start to salivate is very, very high, because we do have indeed the same neural circuitry that allow that to happen. And this is very important because we can make this assumption, it's very neuroscientifically sound, that the person in front of us will get it. Okay, it's a very comforting thing to think about. We are made of the same stuff, neurologically speaking. And so when we use positive affirmations, we are rehearsing an emotional virtual hug, you could say, to the person. It's something very similar to what we could conceptualize within healing touch, for instance. Okay, we're massaging the soul of the person in front of us. And this affirmation, by the way, are predicted upon what the client is sharing with us. For instance, I have been in pain, in excruciating pain for the last 3 weeks. I haven't been able to do anything. This is frustrating, and it makes me feel depressed, and makes me feel I'm not worth anything. And I just wake up in the morning, and I can just prepare breakfast for my kids, and I'm just exhausted. And that's exactly what we want to put the attention to. Positive affirmation, the fact that they can absorb some of their self-pride by virtue of you telling them that indeed they were able to prepare breakfast for their children, for instance, okay? Or the very fact that if something that might appear to be completely negative, they come to you and they give you a list of all the things that did go wrong, so they're not distorting things, that are not a question of cognitive distortion, they're objectively a difficult thing to deal with, and there's really nothing positive. Well, affirmation could also focus on the perceived past, present, and future. The very fact that this thing can be interpreted as a stage. Okay? We'll expand on that because physical pain has a lot of commonality with clinical depression in the area. This distorted notion that makes the person seemingly unable to foresee a more positive future. You are literally frozen in time. Okay. Now I'll conclude here because we're only on slide number 3. Reflective listening, as the name implies, simply means, well, it means 2 things. One, it means that you are indeed listening. Okay. Now this also might sound very commonplace, and yet we know this full well very often in our profession in healthcare. And my field is psychiatry, of course, but this is true for many other subfields of medicine. If we don't pay attention, we tend to enter a conversation in an automatic autopilot mode, and we just check all the boxes. Okay, you have this, this, and this, and this is the procedure, or this is the clinical intervention, or this is what to expect. But we might not actually see the person for what they really are. They're almost see-through, almost transparent from us. Okay? Now, there are some areas as to why this approach it's good, because you have to master a solid biostatistical evidence-based analysis. So you should be able to use heuristics. We call this in medical philosophy. Heuristics are techniques that allow to jump to conclusion in an informed sense. For instance, a person comes to you and reports a cutaneous infection. You should be able to rule out anything else that has not to do with either a bacteriological or viral problem, for instance. So you can jump to conclusion, but the risk is that the person might talk for half an hour and you were not really there. Okay, and this, of course, prevents the person for either trusting you fully because you appear to be cold-hearted and distant, and B, it might have a very detrimental effect for themselves because they might even feel, well, I'm nowhere as smart as the doctor in front of me. Maybe my pain is not even real, or maybe it is real, but I don't deserve to share how painful it is because the person in front of me obviously doesn't think it's a big deal. And that in turn adds some more guilt and frustration. So this is the listening part. The reflective listening is unpacking or repackaging what the client or the patient just shared with you in a nurturing way. For instance, the person might come to you, and I'm kind of exaggerating the presentation here to make the point, saying that I wish I didn't drink so much when I was younger, and now I have all these problems, and I'm kind of too old, and what's the point anyway? Sure, I might have cancer at this point, but I'm just too stressed, and this is definitely not the time in my life to start working on myself. Just too much stress. And if I wasn't able to focus on myself when I was 20, now I'm 70, there's no way I'm ever going to change. It's too late. I wasted my time. So what's the point? Okay. So a reflective listening approach does not present a biased perspective. even though you might start from a good place, you want the best for your client. But reflective listening technique will represent what you just heard in a nurturing way. For instance, well, it's like you are feeling that in your past, you did not address those issues as you were supposed to. It sounds like that you don't use an I pronoun. You never say, well, I feel that you did all things wrong, okay? Or even if it's too positive, well, I feel there's plenty of room for you to change, but you cannot make false promises simply because that means that you're not paying attention to the client, okay? So everything that starts with, it sounds like, it feels, and by the way, those things are not necessarily synonymous. You want to be very well informed as to what you use. I feel like when there's a more emotional, visceral, body-related, felt type of sharing, and it sounds like where the client, for instance, talks about their goals and the goals of their family, right? For instance, I've been dealing with this pain for the last 5 years, and yeah, I'm not as strong as I used to be, but as long as I stay in bed most of my day, it's kind of manageable. But my family keeps nagging me. They want me to go out for walks, and they want me to go out for hikes, and what's the point? So this will be, it sounds like on one side your family really cares about you. Now, of course, this is a biased assumption, but notice how we're not falling from the negativity. We're not distorting what the client's saying, but we're just simply switching the statement, my family is bothering me, is nagging me, to, well, it sounds like your family cares about you. But careful here. You don't want to push too hard in saying that, well, you should be more empathetic toward them. You should be grateful, because if you're already in pain, you're physically unable to do that. There's plenty of research that can indicate that the pain, both physical and emotional, has some side effect that really appear to increase the perceived self-centeredness of the person. In other words, you're in too much pain to literally deal with anybody else. You're too focused because the pain is consuming you from inside. Okay? And by the way, this is an area of a very fertile ground to work with, because there's wisdom that, of course, can blossom from suffering. Suffering has an intrinsic meaning-making capacity, okay? So that will ultimately ameliorate your empathy, because you'll be able to relate to other people that suffer just as you did. But in the midst of pain, acute pain setting, this is very often impossible for the system to deal with. Your cognitive process are too focused on your pain perception. And this is simply because the pain main responsibility, at least in an acute pain setting, is to wave a red flag so that you can take care of that pain. Okay? And the final letter here, summaries. Summaries are pretty much a combination of multiple reflections, multiple reflective listening. Okay? Well, why are they important? Well, two main reasons. One, again, because you want to make sure that you pay attention throughout the conversation, and you also help the client navigate their priorities. Okay, very often when we struggle with pain, there's a commonality of intent, and yet there is a very broad spectrum of multiple problems. Okay, first of all, the pain has this capacity to spread, both metaphorically in a cognitive sense as well as physically. Okay, and also it might impair further and further areas that will negatively affect your life. So this is one reason. The second reason is because with summaries, you can plan ahead. You can show the client you are invested in their care, and you really want to see them again. And this, again, could mean a variety of things. Could mean, so you did analysis of everything they struggle at this point, and you want to investigate why they think they should do A, B, or C. Okay. So let's stop here for this slide, because then there's another acronym that will help us navigate this a little further. So the next slide, we talk about why pain and perceptions is so important. I don't want to spend too much time here, because many of my colleagues already discussed this in depth in terms of how the neural mechanism underlying pain perception are constructed. But the first thing that I want to mention or just review with you is the fact that we cannot separate pain from sensation, from perception. Okay? And again, this means a variety of things. The first thing is that, let's be clear here, there is always hope, because pain exists by virtue of being constantly regenerated. Okay? Pain exists first, especially in the setting of acute pain, because something sends a signal. And in this little diagram here, I just use an inflammation of the GI tract to make the point. And also because, the GI tract, the gastrointestinal tract, has a variety of fascinating factors associated with the production production and stimulation of neurotransmitters, serotonin especially, and the fact that we can literally say that you are, to a very, very extent, what you eat. Okay, so we can see here that you have an inflammation at the level of your gastrointestinal tract that eventually, thanks to the ascending pathway, reaches your spinal cord, and you have this nociceptive mechanism. So nociceptors are, of course, receptor for pain. And then from your spinal cord, and you have that decussation, is crossing over and goes all the way to your brain or to your thalamus. And again, so this means that pain is generated and regenerated across space and time. So pain flows just by virtue of neurological processes. You have a stimulus that is simply the interface between the outside and the inside. Always keep that in mind. Our body is an interface between us and the world. Now, I don't dare to venture to existentialist philosophical arguments tonight, but you could at least visualize a sense of self, whether you want to conceptualize that as a soul or a mind, or at least a psychological process, as something that defines to some extent who you are. You have an awareness of that, but this awareness is, as we say in cognitive psychology, part of embodied cognition. Your body is the temple of your soul, so to speak. And so if you have a pain stimulus inside your body, the body is pretty much the filtering mechanism that allows the brain to make sense of what's going on. Okay, and so this is what I mean by sensation. It's an aesthetic process, and aesthetic, in the Greek etymological sense of the term is sensation. Okay, a perception filtered through the senses. So this is the space, and of course, through time, there's a significant difference between acute pain in the moment and chronic pain in the future. Okay, and it's very, very similar to what happens to acute stress as opposed to chronic stress. Again, I don't want to take too much of your time, but you can just think about the role of the HPA axis, for instance. I did not include a slide here, but the hypothalamus pituitary gland, right? The fact that there's a variety of processes involved there in corticotropic factors, like cortisol, skyrocketing. So the fact that your interpretation, conscious or subconscious, and to mention this, will limit your ability to move away from the pain. Because if the pain itself has ceased to be informative, okay, ceased to have the main notion of, again, raising this red flag, well, there is no biological need to keep feeling the pain because you, quote unquote, got the message. But very often this message is buried in, whether you want to use a psychoanalytic framework, subconscious or preconscious, or simply a pain that is somatized in the context of behavioral medicine. This is what usually happens across space and time. And some of my colleagues mentioned fibromyalgia, for instance, an example, or any type of skin rash. From a neuroscientific behaviorist component, what I can say is that with a fair degree of certainty, and the reason why I cannot say with 100% degree of certainty, despite the fact that we should never use 100% in any scientific research, is simply because the general idea is that pain is a message, and it's a message that might stem from a physical problem, internal or external. It can be internal infection or a traumatic, brain injury, an external factor, or just something emotional. But it has a start, so to speak, as a begin. And then if we can pay conscious attention by virtue of using our emotional cognitive process, well, the pain already feels hurt. If we don't pay attention, then very often there's a cascade of progressive deteriorating factor that occurs. As you can imagine, this process follows the neuroanatomical and in general, the broader anatomy and physiology area of the body. So it starts from the biggest organ in our body, which is the skin. So skin rash or rosacea or psoriasis. Oh, there's a bit of a feedback here. And eventually it might go deeper physically and metaphorically deeper all the way to a gastrointestinal tract, affecting multiple areas in our body. So here's the idea. So pain perception as a sequence both in space and time. So in the next, I want to talk a little bit about how this happens. Part of the title of this presentation was nociceptive factor, nociception. So what does nociception mean? Let's see if it's a little bigger for you here. Nociception is a compound, nocere and capere, which means two things. Well, nocere is like being negative, or at least having a negative art, right? Both, although it wasn't really created by Hippocrates, but primum non nocere. The first thing is do not harm, right? That's a nocere, right? So nocere is anything that harms the system, physiologically, emotionally, physically. And capere, it's even more interesting, is to grasp or to catch. Okay, so just hold on that thought, for instance. Okay, so catching harm. Okay, the same way as you catch a cold, you're catching harm. Okay? That's nociception. So nociception indicates is a sensory nervous system process of encoding noxious stimuli. So stimuli that are negative, that are potentially threatening. This term was coined to distinguish the physiological process from pain. So the physiological process is, so to speak, objectively true. Okay, nervous activity, whether you can actually follow the action potential across the neural pathway, okay, across the afferent or afferent neurons, right? There's always this feedback mechanism, right? So afferent, it's the neural pathway that connects the limb, the aching area, to the brain, spelled with the A, adfero, right? And afferent, spelled with the E, is away from the brain to the limbs, right? So think about the somatosensory cortex in the brain, for instance, right? As opposed from pain itself, which is by definition subjective experience, because we are always, I am always myself feeling the pain. Okay? The pain does not exist outside of me. I'm the one feeling the pain. So let's go back here to this capture, this catching. So keep this in mind. Open a little window in your cognitive processes here in your brain, figuratively speaking. Just leave it there. Okay. Now look at nociception. Nociception involves four major processes: transduction, transmission, modulation, and perception. Okay? And each of these pretty much mean the same thing from a different angle. Okay, so transduction has to do with leading something from A to B through something. Transducere in Latin. Okay, you're leading something. There's a process. There's a sequence in time. Okay, transmission is similar to transduction, but also has to do with a meaning making. Okay, you're putting something with a meaning. You're reassessing the order of things. Think about what cells do in a developmental context when they quote unquote decide to become neural cells, for instance, as opposed to cells in the gastrointestinal tract. Okay? Modulation and perception, by definition, have to do with the ability to navigate the ups and downs of the pain. Okay, whether the pain is more or less, or it has a different aesthetic flavor, you could say. Okay, it's more stinging pain, it's more throbbing. Okay, and then perception again has to do with this capture, this ability to grasp. So let me explain what I mean by that. You could almost say that if you're not aware that you are in pain, well, you guess it, you are not in pain. And what does that mean? Well, it means that there is something that is rehearsed internally. So the concept to catch something is the concept of concept itself, all right? Now, I promise not to be too philosophical already in this presentation, but when we think about pain, we think about something that exists independently, simply as a stimulus, but then we are the one attributing meaning and value to the pain, okay? The way we conceptualize pain will ultimately determine the way we feel pain, okay? And so, can you say that you can get better at feeling pain? Well, that would be a good place to start. If nociception is the standard baseline ability of your body to feel just enough pain in order for you to pay attention, okay, then there might be a place where, for evolutionary biology perspective, too much pain does not actually add knowledge to the system. And so part of your work on yourself, the work on yourself that you can done, that can be achieved by virtue of, again, applying motivational interviewing, is understanding what that means to you, okay? Whether you can not change the pain itself, okay, because the idea is that you cannot change the stimulus. You cannot go back in the past and delete the stimulus, but you can change your sonic chamber, the way the pain reverberates inside of you, okay? And again, concept is the best way to determine this. It's something that you build together, right? All right, so now, all things considered, in slide 6 and 7, I want to give how this all fits together. Slide 6, this one will be a general discourse, a general overview, and slide 7 will be the second practical acronym that we'll like. So we mentioned that the pain is, physiologically speaking, something that is important to understand a stimulus and raising attention to that aching limb, for instance, okay? And so you already have two parts of this equation. One is the aching organism, yourself, okay? And the outside would be the aching stimulus. Now, as you can imagine, it's even more complicated where the hosts both processes, right? When the origin of your pain starts from within, you might have an internal bleeding, for instance, or even when you don't have the opportunity to point the finger to something physiologically apparent, as in the case of emotional pain. Okay? And so a good framework would be to think about either you are attempting to changing everything else outside of your control, or you try to modulate your own self-control, okay? Careful here. By self-control, we do not mean suppression or repression of pain, okay? This is something that should be common sense, but very often is misinterpreted whenever we think about, well, the pain is in your mind. Just try not to think about it. Yes, I wish I could make that claim, but it's never going to work. It never will. Simply because the very organic structure you use to suppress the pain is the same structure that is using the pain to make itself hurt, which is your brain. In any way, so psychoneurological pathways to build resiliency. Resiliency means the ability to modulate without allowing too much pain to, let me use a metaphor, to scream unnecessarily because you already got the message, okay? A, behavioral components, and B, cognitive components. Now, I want to admit my bias here. This is a very much a behaviorist attitude, okay? And in this slide, I kind of move away from any too philosophical or psychoanalytical frameworks, but more of the way we interpret, mind-body connection in a biomechanical modality, the way we do this in the West, at least. Okay, so think about cognitive behavioral therapy, for instance. Okay, so the first examples for learnable behaviors, patterns, or habits. First element, down-regulating anxiety, fear, and stress. Second element, balancing, enhancing, improving physical health, which in turn has to do with resilience. Now, let's start from the first part here. This one has to do with one of the most common strategies within clinical psychology or psychiatry to target things such as panic attacks, anxiety, or any type of overreaction. Those strategies are very useful to monitor pain because, again, pain is immediate, is acute, but eventually can become chronic if we don't pay attention in the right way. Either we pay too much attention and we're being captured by this pain, or we try to pretend that the pain is not there. So how to down-regulate anxiety, fear, and stress? There's a variety of possible strategies, a lot of which has to do with many of the things that many of my colleagues mentioned in the primary discussion. You can think of mindfulness. You can think of meditation. You can think of physical exercise. But even more important, all of this, as important as they are, is understanding that you can retrain your brain by virtue of showing your brain that there is no further need to be overactivated. What do I mean by that? Well, for instance, think about a combination of pain and anxiety, something that happens very, very often. A person who might have had, I don't know, a sports accident, a skiing accident, for instance, right? This person might be in constant pain, but they might even report changes in pain acuity depending on temperature, for instance, when the season changes, for instance, okay? When they move toward winter, or when they have any type of audio-visual stimulus, such as seeing someone else skiing and maybe falling, okay? Now, before we discard all of this as example of either cognitive distortion or synesthetic exaggeration, and this person is just too emotionally sensitive, which is, of course, wrong from a scientific perspective, we can use this to our advantage. So one of the classical strategies in clinical psychology that is actually combined with motivational interviewing is to allow the person to slowly and progressively face what they think it's hurting or anxiety provoking. Now, let me rephrase this, okay? When I say what they think, I do not mean they do this because they're either naive, or they're gullible, or they're weak. No, it's they think simply because we are talking about neurological processes, okay? I mean, the pain is in your brain, or at least it is at least in your brain, because of course, we won't even talk about embodied cognition as a whole, the fact that our body has its own emotional intelligence. So it's not just located in the brain, but it's where we interpret it the most because, you know, especially in the context of the thalamus and the pituitary gland, you know, this area combines corticotropic activity and a nervous mechanism, the nervous system, or hormone-based mechanism, your endocrine system. So one of the classical strategies is progressive exposure with relapse prevention, right? Or response prevention. So you allow the person to face slowly what they're interpreting as a problem, and then retreats when the stimulus is too strong. This is what you would do in PT, for instance, when you do physical therapy exercise, in which you might work on ROM, range of motion, okay? It's still aching, creates a discomfort, but you enhancing the ability for your somatosensory cortex to understand that, yes, this is painful, but it does not have to be that painful, okay? Slowly and progressively. Or if you think about anxiety, a person who might suffer from agoraphobia, for instance, this person has been unable to go and buy groceries because, you know, every time they enter, you know, a grocery store, that they have experienced a panic attack. So you navigate with this person the possibility to expose themselves slowly in progressive small steps and then retreat when the stimulus is too strong. In motivational interviewing does that, but in a virtual scenario. You're doing this by a discussion, by an interview. And so you are actually allowing your client to manifest outwardly what they feel inside by virtue of doing what we said before. So it sounds like this creates a lot of discomfort in you. I wonder if you could tell me a little more about what is your situation when you go to buy grocery. I wonder if you could elaborate on this accident you just mentioned. So you're investing in creating a new narrative, okay? So this is just for learning about behaviors, patterns, and habits. And B, examples for learnable cognitive, rational, and analytical skills, emotional regulation, and verbal physical expression and labeling of emotion, affect, and thoughts. I don't spend too much time on this one, but the idea is an idea that's been part of counseling, coaching, psychology, psychiatry, since time immemorial, I would say. The first thing is that you can regulate your emotion. Okay, the very idea that everything changes. Okay, it's a very simple statement, but very, very often distorted by virtue of experiencing pain, emotional or physical. The fact that the pain moves the suffering subject outside of space and time. Okay? Now, of course, emotional regulation can also be used in a very strict clinical intervention. If you think about DBT or dialectic behavioral therapy, and there are specific areas of intervention. But in general, emotions, similar to what we just said for nociceptive factor, simply indicates moving from place A to place B. Ex movere in Latin, moving away from something. Okay? So emotions are other forms of languages, the same way as thoughts are forms of languages. Verbal physical expression and labeling. This is, of course, easier said than done, but the idea is that we can improve or create new obstacles for feeling better when such labels that we put on become redefiners of who we are. Example, think about motivational interviewing associated to a combination of physical and emotional pain. Think about addiction. Think about alcohol addiction as an example, okay? There's a variety of very biologically, physiologically based negative experiences, nausea, vomiting, muscle cramps, progressive deterioration of cognitive functions and memory and deterioration of musculoskeletal abilities and so on and so forth, on top of course, impaired emotional capacities. And so in this context, we can navigate the importance of, for instance, doing things such as labeling yourself as an alcoholic. Think about AA, Alcoholic Anonymous meeting. You enter the meeting and you immediately identify as, my name is David and I'm an alcoholic, for instance, okay? Or, you have a physical problem. I am an athlete, but I am injured. And therefore, at that moment, that's all I am. That's all that really defines who I am. Now, as everything else in the context of mind-body medicine, it is important to label things, because only when you give a thing a name, you're able to control it. This is something that has, mythological origins, even biblical origins. You think about it. You name things so you can have control over them. And also because you externalize them. The moment you label something, you can have a conversation with your pain. Okay? You're figuratively speaking, you're distancing yourself from the pain. This is me, and this is you, Mr. or Miss Pain. Okay, I'm talking to you here. You no longer have full control of me. Even more than that, you're not me. You're part of me, and I want to acknowledge that, and I want to give you the opportunity to feel heard, because otherwise the pain will become even more somatized. Okay, but then once you have a label, you rearrange the label via the things that we just mentioned earlier. You can have this self-dialogue. Okay, I understand that this is painful. I understand that this is what happens. I'm not in a context of denial, but what does actually mean to me? What are you telling me, pain? Okay, and this is, the reason I mentioned here cognitive and rational analytical skills is because we very often, quite mistakenly so, think of rationality as opposite to emotionality and creativity. Okay, there are two things to keep in mind here. First of all, rationality in the context of pain perception should be viewed from a very, very pragmatic sense. So rationality as something built on ratio, based on percentage. So in other words, based on the opportunity to evaluate your pain on a scale, okay? How much are you in pain in comparison to your own perceived baseline? 8 out of 10, 7 out of 10, or 4 out of 10, okay? And by the way, this rational scaling, it's one of the essential technique within motivational interviewing applied to health and wellness coaching, for instance. When we do scaling, okay, we might ask, in fact, the client to share with us how would they rate their pain? But contrary to what seems to be the standard in, for instance, other forms of counseling or clinical psychology, let's assume that the person is telling you, I don't know, you're asking them how confident are you that despite of what you just shared with me, this constant pain, how confident are you that maybe in 3 months from now, you're able to reconstruct your daily schedule the way it was before your injury? Okay, how confident are you? And they might say, well, I'm not really confident, you know, I'm maybe just 5 out of 10, just too painful. Okay, you know, very often if you come from a non-motivational interviewing cognitive you know, or academic background, the immediate response for a counselor or psychologist, what do you rate this as a 5 out of 10 and not a 6 out of 10, right? Because the idea is that, well, what would it take you to feel better? What would it take you for you to give me a higher rate? Well, guess what? In motivational interviewing, we do just the opposite. Okay, why? I wonder why you rated, you know, your ability a 5 out of 10 or a 7 out of 10 rather than a 4 out of 10. And the reason why you do this is because you're stimulating your client, and by the way, stimulating using exactly the same neural pathway that are otherwise occupied with pain, to feel good about themselves. And they might say, well, you know, yes, well, I rate a 5 out of 10 because it can be worse, right? I mean, sure, I have this pain, but there are times throughout the day where I don't even think about my pain. So I guess it could be worse, okay? But here's the thing. You're not giving this interpretation to the client. The client has to come with this interpretation themselves. You're just asking the further question as to why they rate this as 7 out of 10 instead of a 6 out of 10 or a 5 out of 10 rather than a 4 out of 10. And so there are many reasons why you do this. The first one is because you do not want to label your client further. You don't want to even give the remote impression that, well, you know, your pain is bad, but it's not that bad. Because otherwise, A, the pain will increase for the other reason we just mentioned. The brain doesn't feel hurt. And B, this will have detrimental side effects, again, with the guilt and shame that the client perceives because they feel they're either wasting your time as a professional or they shouldn't feel in so much pain because there are people that get worse than themselves, okay? So if you are labeling that, then you are actually adding judgmentality to the conversation. But the nurturing thing, and that's what research indicates, is that if it comes from the client, if you are doing your job right, practicing motivational interviewing, the client should leave your session, the client in pain, the patient in suffering, not having the thought of, wow, that health coach or the psychologist or the doctor was so good. You need to take yourself completely out of the equation. They should leave the session being proud of themselves, happy about themselves, okay? Which is very often what we don't practice, you know, in healthcare, you know. It might be subconscious. It might be just a question of, well, I spend, you know, hours and money in med school or in nursing school. Please do not confuse my degree with your Google search. You know, so it's something that it's understandable emotionally speaking, but you're doing a disservice to your client. All right. I just want to be mindful of the time here, and I see that there are a few activity here in the chat, so we just barely past 7, so we'll speed up in the last 2 slides, and then the rest is just bibliographical references. Few more practical examples. Slide number 7, another acronym within motivational interviewing, especially motivational interviewing applied to health and wellness coaching, the RULE acronym. R for resist, U for understand, L for listen, and E for empower. So I will read it and then I will explain. R, resist telling them what to do, telling your patient, your clients. Avoid telling, directing, or convincing your friend or your client about the right path to good health, okay? Why is this important? Well, because your client, your friend, your patient, they are the experts. Always keep in mind that being an expert is having expertise. In other words, having an experience that direct, okay? Now, of course, you might say, well, I'm an expert academically, but you wouldn't trust a doctor that studied, you know, I don't know, cardiothoracic surgery online only, right? You would expect someone who has some experience, correct? It's just a normal thing, or a psychologist who never met a person to practice that. Granted, there's a pandemic going on, there are Zoom meetings like this one, but you want to have some sort of experience, right? And of course, who is the best expert about their pain than the person experiencing it? So it doesn't make sense for you to tell them, to direct them, okay? Now, of course, this is not a black and white situation. It is completely appropriate within motivational interviewing to gently guide the client to find new resources, especially if you're a professional who had different areas of expertise. Okay, so it's if a client, for instance, is struggling with pain and never heard of any natural or pharmacological intervention areas, it is completely appropriate to respond to a jump. You simply do not want to jump ahead and tell them, well, I'm the expert on your life, okay? I know what you need to do, okay? So resist telling them what to do. You understand their motivation, seek to understand their values, needs, abilities, motivation, and potential barriers to change in behavior. Classical example that is predicated upon differences in subjective experiences, but also you could say ethno-cultural or ethno-religious, geo-cultural areas, okay? Let's say, talking about physical pain. These are a common element in all spiritual and religious tradition, and this is just an example I want to make. Suffering, sorrow plays an essential role in defining who we are as people, okay? So within healthcare, very often we are, this is kind of a byproduct of the society we live in and the social circumstances that led us to the way we practice medicine to this day. But we are fixers. We want to fix a problem. And for the most part, it's a good thing. We want to make sure that our client feel better. But then this removes the narrative. We cannot remove the opportunity for the client to understand the deeper meaning of what they're experiencing, okay? And also the strategies for well-being. We might think that we might think subconsciously in our mind, well, if you only quit smoking and work on your diet, you'll feel so much better. But that might not be their primary motivator, might not be their primary cognitive priority. And we have to respect that, because just by teaching them in a forceful way, or just, how can I say this, modeling their experience on ours, we simply forfeit the ability to make any change happen. The last two, listen with empathy, okay? So listen with your heart, I would say, with your whole soul, with your whole body, okay? Not just listen cognitively, with your rationality. Seek to understand their values, needs, abilities, motivations, and potential barriers to changing behaviors. Now, see the different thing. The first one, it focused on a categorical, imperative, like Immanuel Kant. But the primary cognitive pattern that you for understand is understanding their rules, okay? The rules, if their life is the game they play, the rules that create the game. Versus the L is more like relating to another person in an empathic sense, okay? And this goes back to the neurological underpinnings of empathy, okay? And I want to speak to this a little bit. When we think about empathy, aside from all the discussion on mirror neurons, what is also interesting is that there are a mounting body of evidence that is starting to, I wouldn't even say slowly, because it's a very significant mounting body of evidence that indicates that what we thought to be the primary difference in somatic localization between right and left hemisphere still holds true to some extent. And just to be mindful of your time, think of your right hemisphere as the creative, figurative, artistic part, and the left hemisphere as the more analytical, rational, cognitive part of your brain. This still holds true to some extent, albeit with a lot of overlapping magisteria. Think about, language areas are almost entirely on the left hemisphere. Think about Broca's and Wernicke's area. But in terms of the research that has been indicated, what happens if you have a, semi-lateral stroke, for instance, stroke only on the left hemisphere or opposite on your right hemisphere. The interesting thing is that the right hemisphere does quite well without the left, but not the other way around. But the interesting thing is that the right hemisphere might do just well, or at least well enough, but it's not fully aware in a sense that it cannot verbalize it, because all the rational and verbal skills are mostly located in the left hemisphere. So it's the same thing with empathy. you need to get it emotional. You need to listen with your soul. Okay, this might sound a little new agey as a concept, but it's actually what neuroscience clearly indicates. The very moment we rationalize and we conceptualize something, this becomes clear, or at least clearer, but it still becomes a short summary of the complexity of it. Okay, so especially about pain. What is your pain? Well, my pain is, let's assume that you have anxiety, right? I feel this heaviness on my chest. Okay, define it with me. Well, it's like a stone. Okay, also doesn't mean that it's something that is very, I don't know, it's like, whatever, 4 by 10 inches. And no, it's not quite, it's hard to verbalize. And that's why it's important to listen with empathy, because there are variation to the modalities of existence, simply because the pain again exists in the body, and let me use the term, the soul of another person, not in yours. Finally, empower them, work with your friends or clients or patients to set achievable goals and to identify techniques to overcome barriers. This is the last portion, and I will just conclude with this slide, which is a last example of this. And so we have 10, 15 minutes for questions. And this is the last acronym built upon ORS and rule, and it's the oldest of them all, the darn cat. Most of you probably already heard this before. Okay, so I'm not sure if you can see the cursor because of my mouse here, but you still have, the open, the ORS acronym here. Okay, so you have a general spirit at the basis of using motivational interviewing for pain: autonomy, collaboration, evocation, so give voice to the person who is suffering. Okay, then the principles that are connected to the rule acronym, these are spelled slightly different, but they mean exactly the same thing. And then you have ORS, which means what you're actually doing: open-ended questions, affirmations, reflections, and summaries. And then what is happening as a result of your doing this is predicted upon these two main elements: the darn cat: desire, ability, reason, and need. I'll explain it in a second. And then the cat: commitment, activation, and taking steps. In conclusion, since pain is internally perceived and subjectively felt, our job is first to shed light appropriately, to manifest it outwardly, so we can have the chance to discuss the pain so that the client does not feel the burden hanging on their shoulders alone. We can put our shoulder to help them carry that. We don't solve the problems for them because that would be detrimental. The solution has to stem from them. But we do this in a nurturing, empathetic way. And then the recommendation, the homework, so that eventually you have to find a way to monitor whether your research, your clinical intervention works, so it doesn't just stay on the theoretical, philosophical realm, is doing this. You monitor your client desires, again, their principle, where they want to work first. Let's assume that they've been bedridden for 3 months. You cannot ask them to just start PT as if nothing happened. You might wonder if they can exercise, maybe just by trying to sit on the bed every morning for 10 minutes, and then they go back. Okay, so what's in there for them? Their ability, again, from the motor skills activation. Their reason, okay, which is more on the clinical psychology area, but you want to really see what's in there for them, psychologically speaking. And the need that can be predicated upon an external motivator. Okay, it's not a wrong thing if a client wants to work on their physical activity because a family member wants them to feel better. Okay, it's something that we have to navigate with care, but it's not necessarily a bad thing. And then commitment, activation, and taking steps is again predicated upon the fact that everything changes. And if you shed light appropriately with your client, they're able to see themselves as just a part of a sequence. Okay? A sequence that in the future will be a better future than the hypothetical future that they see so far. And this hypothetical future be negative as a result of their pain taking over. So I think I will stop here, and I'll be happy to go back, but let me just make sure that I stop sharing here and I'll start the chat. So I'm not sure how you want to do this, Janet. I mean, I'll be happy to read the questions or...
Well, I only see one question. So if anyone wants to speak up verbally, feel free to do so. Or if you want to type it in the chat, please do. And I can read the first question and maybe you can start there. You mentioned that feeling guilty is not a great motivator, and that when a person experiences feelings of guilt, their brain does not feel heard. Will you please speak to the neuropsychology of guilt?
Thank you. Yeah, phenomenal question. Yes. Yeah, I should probably rephrase this because there is definitely a benefit of guilt. Okay. In a sense that, so let me use this as an example. There's a variety of meta-analysis, so combined evidence-based, clinical trial, double-blind studies in clinical neuropsychology clearly indicate that the sense of guilt is predicated upon a variety of factors, but especially community, ethnic, cultural, religious factors, four main areas. And some of the, I can't think phrases, some of the geocultural ethno stereotypes still hold true to some extent. So for instance, there are some cultures that neurologically speaking, obtain as the highest motivator pleasure resulting from success. There are other cultures instead that achieve the same result, so academic excellence, for instance, not as a pleasure stemming from success, but as guilt or fear of possible failure. Okay, this is psychology speaking. It's pretty easy to explain away. Just think about operant conditioning, for instance. Any type of conditioning is predicated upon those, right? And so in practical terms, a student might be a straight A student throughout a semester because they really feel pleasure in getting an A each time, and they feel the positive outcome in being praised all the time. And another student in the same course might also get straight A's, but simply as a existential fear of getting a B plus, which determines the failure on their side. Okay, so the result is the same. Now, what is interesting that there are different circuitry in the brain that are predicated on either. It's more of a gradient. It's not a black and white. Which percentage takes over? Is a more pleasure experiencing, not pleasure seeking necessarily, pleasure experiencing, or is it more guilt avoidance? Okay, and those areas, as you expect, are connected to the interconnectivity between the limbic system and the cortical area. So the ACC, the anterior cingulate gyrus, the nucleus accumbens, and all of those areas are definitely connected to guilt. Now, guilt itself, it's also extremely important for meaning making. Okay, and if you remove guilt entirely, you're really depriving the person the opportunity to feel better. Because neurologically speaking, guilt is very similar to biological suffering. So think about physical exercise. The reason why you can actually affect your G fibers and your muscles, and so your G fibers will feel like, for instance, you're doing 4 sets of 10 repetition of push-ups, for instance. Okay, so your muscle will interpret as a burning pain that eventually will stimulate the muscle to pump more oxygenation area, via blood flow to the area, and eventually over it will be consistent with the procedure between catabolic and anabolic effects, so your muscle will increase. So it's the pain itself that's a stimulant. Okay, so if you remove that, for instance, rather than going to the gym, you think that just by reading a fitness magazine, the same thing will occur. This will not happen because you need that pain as a stimulus. It's something for guilt. So when I say feeling guilty is not a great motivator, this is true, definitely true in the context of motivational interviewing. Because a person that comes to you already comes from a position of hierarchical difference, where you're here and they're here. So they're already feeling there's something it's not quite right. Now, if they brought themselves to you, this is already self-apparent, because I wouldn't be seeing you if everything was okay. But this still holds true if they're being referred to your clinic, to your office by someone else, because that's another labeling element. So I hope I made the point in answering this question. If not, please ask me again.
Yes, thank you. There's another question from Deborah Hines, who
Yeah.
asked, you mentioned that pain increases self-centeredness and ameliorates empathy. Can you explain the mechanism driving that?
Absolutely. All right. So let me start with the first one. The first one is it's really easy to explain. In a sense that what the brain does, the brain is constantly involved in self-management. And by that I mean making sure that the prioritization of biological processes is crystal clear. These elements can be very complex, but just to give you an example, in neurodevelopmental terms, what the brain does already, the first couple of weeks of gestation, it kind of blossoms like a flower. So the innermost part of the flower, it's consistent to, the areas you can find, in terms of the basal ganglia and limbic system. And then the external part is the cortex, the external part of the brain, that fully develops only toward the end of gestation. In fact, the prefrontal cortex is not fully developed, until you're like, 19 years of age for biological female, about 20 to 21 biological males. And the interesting thing is that the central part of the brain is the one that we share the most with other animals, especially mammals. So it's the innermost, you could say, animal-esque, visceral, intuitive part of the brain. Okay, and so if you have a problem, the brain thinks of itself as, well, let's make sure that at least you have biological life in place. Everything else, it's not as important. For instance, when you have an extreme stress response, and it can be, a car accident, physical pain, at first you might not feel any pain because the brain has all the interest in pushing away your cognitive capacity so that you develop enough strength to bring yourself to the hospital. You can really crawl, having internal bleeding, not feeling your limbs, you can still crawl, on the side of the road, for instance, okay? If you have a psychotic breakdown, for instance, or a nervous breakdown as a result of too much stress, you might experience, I don't know, a panic attack or even a manic presentation, okay? So your rationality is negatively affected by it, but from the brain perspective, nothing is more important than biological life. The way you present your emotion and thoughts and whether you act in an odd and eccentric way, it's definitely not as important as making sure that your heart rate is still stable, your breathing rate is stable. So the more pain, the less ability for the brain to dedicate enough attention to these higher functioning areas in the cortical structure, okay? And in that sense, it increases self-centeredness. You cannot be too occupied with many things because the pain itself captures all your attention. At the same time, pain does ameliorate empathy simply because it adds more variation to the modality of existence. This might be a little, I don't know, a little cheesy to some extent, but think about classical. Can you really claim to know what love is if you've never been heartbroken? Can you relate to another human being? Can you know what pleasure is if you never experienced pain? And this is true because it's okay for this. It's true because, first of all, it's not up to you to choose. The pain chooses you and not the other way around. So you're completely at loss for control. So it's a new information that you did not fully grasp until you experienced yourself. But then, again, I want to mention what I said earlier about religion and spirituality. It's not by chance that many spiritual traditions really emphasize the painful element in life. And this is something that I'm not saying it's good or bad, but it's more about anthropological fact. And it's something that's kind of slipping away in our society simply because we're doing all the right thing. We're trying to fight pain. We're trying to fight discomfort, and thank God for social activism and accessibility of care and all those things. But the risk might be this depersonalization of the single painful experience, as in if I am experiencing a grief process, this is something wrong that I need to move away from as soon as possible. And the point is that it's not up to you to make the choice. Now, of course, this can be categorical when you dwell in the pain, physical or otherwise, when your grief process extends, for years to come. And this will warrant a much more in-depth conversation. But in this sense, it can ameliorate your ability to relate to another human. Hope this is enough. There's another one.
Yes, you mentioned, here's another question. You said that a person can change the way that pain reverberates inside himself. How can a practitioner foster that change?
Yes, a usual metaphor I use all the time is, as a person in therapy, or, seeing your doctor, your practitioner, your health and wellness coach, you can always borrow, quote unquote, someone else's brain, or you can always borrow someone else's heart. In the first example, you might think that this is especially true if you're experiencing a depressive state, and you might be victim of what we refer to as cognitive distortions. Okay, you might magnify, for instance, the importance of certain areas of your life, or you might, I don't know, disqualify the positive, or you might have a very low self-esteem. So borrowing someone else's brain simply means talking to someone else who doesn't feel the same way you feel about certain things, and that can shed light on the fact that you might be misinterpreting something in your life. Classical example, just to make the point here, you're presenting, I don't know, you're in a classroom, and it's the end of the semester, you're presenting your paper in front of everybody else, and all students tell you that your paper, your presentation was wonderful. There was just one student tell you that it was really that great. You can only think about the negative comment, and it's part of what we do as human beings is predicated upon neurobiology. And so if you meet with another person, tells you, no, you might misinterpret this. The truth is that 20 people told you that your paper was good, and the only person who told you it wasn't good wasn't really about you, but simply because they might, explain to you, because they were not understanding where you're coming from. So in the end, it doesn't really say anything about you. So this will be borrowing someone else's brain. Borrowing someone else's heart is the same thing, but moving from the emotional standpoint. The fact that it allows you to allow your emotion to reverberate appropriately, because your emotional echo chamber is negatively affected by the pain. You cannot feel, like, classical example would be, if any of you has children, or at least has the chance to be surrounded by children, might not be yours, but family members, etc. If you have a headache, you know very well that you're not quite there. You might be you have a short fuse, and you're not ready to listen to a screaming child. You just don't have the patience, and guess what? Immediately you feel guilty because you don't have the capacity. So helping navigate this complexity with other human beings allow your pain to feel heard and then reverberate appropriately.
Interesting analogy. There's one more question. Before I read that question, I want to point that I put in the chat our UVM Integrative Health and Wellness Coaching Certificate for non-degree students. So for adults who are not, that are already professionals that want to study motivational interviewing and health coaching. We have that program available at UVM, and I put a link to that program in the chat. And for our final question, Donna Porter asks, client or patient presents with acute pain, but does not have the ability to see a life without this pain. Mm-hmm. How can we as practitioners foster a move or a shift to reframe this more positively? Mm-hmm.
All right. It's a wonderful question. I would say this is the question. It's not from the philosophy. All right. The first part of my answer will be just a pragmatic one. From the cognitive standpoint, whether you are imagining a positive future or a negative one, the cognitive expenditure, the time, the value of cognitive process that you need to spend in terms of energy is exactly the same. So you still have no evidence, but it's like, again, I like to use practical example. Let's assume that a person wants to go to the gym, not because they want to lose weight, but just want to build up muscles, and they to be, very fragile and skinny, and they look at themselves in the mirror and say, no way I'm going to become a bodybuilder. Okay. Well, you can either imagine a positive future, assuming that it's positive for them, they're not starting with steroids and creating more damage, but assuming that they're doing bodybuilding for the right reason, you have the same cognitive, work to do, whether you imagine yourself in 5 years from now very bulky or even worse. The main difference then, setting yourself for positivity will actually allow you to do the work. So that's the first answer. Okay. Now, of course, this has to be done depending on what kind of frame, cognitive and emotional framework the person stands from. And this goes back to what we said earlier about guilt as a motivator or as an obstacle. There are people that benefit from more like a, army general coaching modality. You do this, you can do this. And there are people that need more of a nurturing thing. And in the end, the answer to this is we function as human beings, again, based on this reverberating effect from childhood, I dare to say. So this might be a little too simplistic because you can have a perfect childhood, nurturing environment, no stress, and still get depressed in the future. The same way as you can be a wonderful athlete, so you do all the right thing, but you can still get an injury. So, this is not always linear in the sequence. But in terms of building resilience, it's known fully well based on research that if you have quote unquote enough love as a child, and by enough simply means the way you perceive that, this builds up your inner strength so that you don't need a constant reminder of love in the future. You're very much self-sufficient. So to the point that if you can embrace another human being, figuratively speaking, that you bring forth the best of yourself, as opposed to when you were either abused or deprived, when there's always this existential hole that needs to be filled, there's this pool. And the same thing happens to pain. Well, the first thing to keep in mind is that there was a person before the pain. And this is very true for two main reasons. The first one is that if the person was born with pain, the perception of pain is usually not high because the person does not know a life without it. And so the brain itself does not interpret that as an intrinsic obstacle. It's just being born blind, for instance. If you never had the capacity to see, you don't experience that as a handicap because you don't have the opportunity to see anything else but that modality of existence, okay? But if the pain has a very specific sequence of development where you have either a cut and dry begin or a progressive deterioration, the person existed before this happened. And so this is an area where you can find room to work with. And again, this is not metaphorically speaking true. Go, if you don't mind, try to close your eyes and go back to the first 10 minutes when I said, if I'm asking you to really pay attention and think about sucking on a lemon, most likely you start to salivate. The very fact that we can think about something creates this scenario internally. Now, let's do not underestimate what children do. Children do this all the time when they practice make-believe type of games. They create a new scenarios without having any scientific evidence of that. Let's pretend I'll be an astronaut, for instance. Well, if you pretend enough, you'll be one. And so this is an area where you can foster this move by understanding that your perception is negatively impaired by the pain. And this is kind of a catch-22, and I conclude. The more you pay attention to the pain unnecessarily, with the pain already communicate its messages, the more you are inflating the strength that the pain has on you.
We are out of time and we're out of questions, which is wonderful. Thank you. That was wonderful, Dr. Tomasi. And I just put in the chat your link to your profile again. So if anyone has questions later, they can click on that profile and find your email address and contact you directly. And I encourage you also to check out our UVM Integrative Health and Wellness Coaching Certificate if you want to take a class with Dr. Tomasi and have an entire semester of these wonderful discussions.
Thank you very much. I appreciate it.
Let's see, thank yous. Okay, everything else is just thank you, thank you, thank you. So thank you.
All right, wonderful. Go in peace. Thank you very much.
Have a wonderful night.
Bye.